My name is Subhi Al'Aref, and I am an interventional cardiologist at the University of Arkansas for Medical Sciences. As part of my research work, I have published on several applications of machine learning within cardiovascular disease. And for this session, I will present on the topic of deep learning for cardiovascular imaging applications. For disclosures, I'm currently funded by the National Heart, Lung, and Blood Institute, and I receive royalties from Elsevier for a book that I was the lead editor on, titled Machine Learning in Cardiovascular Medicine. I have been in clinical practice for the past 10 to 12 years, since graduating from medical school. During training, we are taught and mentored to practice medicine in a specific sequence. The usual workflow entails obtaining a comprehensive history with documentation of symptoms and prior medical events. The next step is to examine the patient, followed by performance of blood work and usually obtaining an electrocardiogram. Based on the above, a differential diagnosis is established, and based on most likely disease condition, a diagnostic imaging test is ordered, which can include an echocardiogram, a stress test, an MRI, or an invasive coronary angiogram. At this stage, a diagnosis is established and a specific treatment plan is determined. However, there are several intrinsic limitations of the aforementioned workflow that I will highlight over the coming few slides. Firstly, symptoms are not often reliable, as many patients deny or minimize symptoms, and some have atypical presentations. The figure is a radar plot showing the frequency of atypical and typical chest pain presentation in men who are in blue and women who are illustrated in red. On the right is the presentation in patients who end up having a heart attack, and it shows that a proportion of patients, predominantly women, present with atypical symptoms. On the left is the presentation in patients who end up not having a heart attack, and it shows that a more significant proportion of patients present with atypical symptoms and is equally distributed between men and women. The physical exam is an important part of clinical assessment and is heavily relied on in order to establish a specific diagnosis. However, the physical exam is not very accurate. In a survey of 30 pediatricians who blindly examined 37 children with murmurs, sensitivity was 82%, meaning that 18% of children with significant murmurs were missed, while specificity was only 72%, meaning that 28% were thought to have a significant murmur, while in reality the murmur was benign. After further testing was performed, likely an echocardiogram, specificity improved to 98%, but sensitivity remained in the 80% range. In addition, a physical exam is not consistently performed. In a survey of primary care physicians, cardiologists, and cardiac surgeons from 7 European countries, only 54% of patients with known severe mitral regurgitation were examined and listened to during clinical assessment. Thirdly, acquiring imaging studies can be labor-intensive and time-consuming. In order to acquire a scan, it requires extensive technical and interpretation expertise, which by itself requires many years of practice and experience. Scans are also labor-intensive, and other than scanning, they often require manual annotation of structures and determination of measurements. In addition, there is significant intra and inter-observer variability when imaging studies are interpreted. Furthermore, imaging studies have become a central aspect of clinical care. When someone presents with a cardiovascular ailment, a diagnostic imaging test is almost always ordered by the evaluating physician, and findings on imaging scan can guide downstream management. We live in an age where numerous imaging modalities exist and are available for clinical use, which is something that did not exist in the distant past. It includes echocardiography, which is an ultrasound of the heart that provides dynamic images and information about the structure and function of the heart and valves. There is cardiac computed tomography, which provides non-invasive details on the anatomy of the coronary arteries and the distribution of plaque, as well as the heart chambers. Cardiac magnetic resonance imaging provides high spatial and temporal resolution images and is useful for tissue characterization as well as functional assessment of cardiac structures. And finally, invasive coronary angiography, which has been around for many years and is considered the gold standard for not only diagnostic purposes, but it also provides an avenue for percutaneous interventions. Finally, risk assessment is crucial in management of patients. Yet, risk scores are far from perfect. Current scores include a limited number of well-established risk factors. Statistical modeling that is often used assumes a linear relationship between risk factors and a specific outcome. Further, they use restrictive modeling assumptions. And finally, there is minimal integration of imaging data, which are mostly used for diagnostic purposes, but not often used enough in an integrated fashion for prognostication. The bar figure on the right is an analysis from the REGARD study, and it shows a consistent pattern seen in similar analyses where risk scores under or overestimate risk at the higher and lower end of the spectrum compared to the actual observed risk. And despite all we do, cardiovascular disease remains a significant cause of morbidity and mortality worldwide. This is data from the WHO, and it shows that cardiovascular diseases are the leading cause of years lost in China, India, and North America. It is followed by neuropsychiatric disorders and respiratory disorders, which might be on the rise in the era of COVID-19. The expansion of machine learning provides an opportunity to improve clinical care by capturing the strength of both machine learning as well as standard statistical approaches. Machine learning provides data-driven modeling, employs an agnostic approach for data analysis, which can provide knowledge on new associations that were previously uncovered through statistical modeling. Standard statistics, on the other hand, provides modeling that is based on previous observations and assumptions and draws inferences from associations between specific variables and a chosen outcome. When leveraging both approaches, there is potential for creating more accurate and precise predictions that is robust to future applications and allows for the integration of actual data as well as images in an integrated and comprehensive approach. Using AI within healthcare promises to improve cardiovascular care by providing quality care, wherein correct information and interpretation is provided for patient care through value by maximizing the amount of data and knowledge extracted from imaging and clinical studies. And finally, by improving access, wherein people all over the world start having access to quality care. Artificial intelligence is a branch of computer science concerned with building smart machines that are capable of performing tasks that are typically require human intelligence. Machine learning is a subfield of AI that focuses on creating predictive algorithms through the unbiased identification of patterns within large datasets and without being explicitly programmed for a particular task. Deep learning, on the other hand, uses multiple layers to progressively extract higher-level features from an input, which is most often an image. In such a manner, These networks transform many problems into a form that can be solved by computers. Deep and more intricate models mean greater capacity, but on the other hand, require significantly larger data sets. This is a simplified representation of the architecture of a CNN. These networks typically have three layers: an input layer, hidden layers, and output layer. This figure shows an example of how a CT image is processed so specific features are learned in consecutive layers of the model in order to segment out a specific cardiac structure. And in this case, it is the cavity of the left ventricle that is shown. And specifically with the integration of deep learning within healthcare, it can help with better image acquisition, and we are seeing research especially with echocardiograms, CT, and MRI. It can improve the workflow associated with image interpretation and reporting, and it can automate clinical decisions. The latter will obviously take time, as it will take humans a while to trust machines and algorithms making decisions on their health and disease conditions. However, it is important to keep in mind that for deep learning models to work, an investment in time, expertise, resources is initially required. Establishing the ground truth when it comes to structures on an image is paramount for model training. However, it requires expertise and can be time-consuming depending on the complexity of the question that is being asked. For the main part of my presentation, and for the sake of time, I will briefly touch upon four areas within cardiac imaging where deep learning has been used. The first part will focus on coronary calcium scoring, followed by coronary CT angiography, then myocardial perfusion imaging, and ending up with percutaneous procedures. The presence of coronary artery calcium has been associated with the occurrence of adverse outcomes. With the more calcium there is, the higher the chance of a future heart attack or cardiovascular death. In addition, the absence of any coronary calcification has been consistently shown to predict a very low yearly event rate for adverse cardiac events. As such, the routine assessment of the calcium score has become an important aspect of patient care. Measuring the calcium score takes time, and in a busy clinical workflow, it can take away significant time from actual patient care. Several groups have investigated the use of deep learning for automated segmentation and calculation of the calcium score. In this analysis by Singh and colleagues, a set of 512 by 512 input images were fed into a modified UNet model with an encoder and a decoder unit. The output was a segmentation mask identifying the presence of calcium in any of the major coronary arteries, the aorta, and any background noise. The investigators were able to achieve an overall DIE score of 0.952 for the task of segmenting coronary calcium. This figure shows an example of the original image showing calcium, which is bright white, and the coronary arteries around the heart. The next set of images are the ground truth labels, and the final set of images on the right show the model prediction. And we can notice the perfect overlap between the ground truth and the model prediction. The color corresponds to a specific artery, while pink in this example shows extra cardiac calcium, which is not usually included in the actual calcium score. Coronary computed tomography angiography differs from routine calcium scoring in the fact that contrast is given, which makes blood bright and hence enables the physician to evaluate the inside of a specific structure as well as the wall and surrounding structures. Coronary CTA allows for the assessment of the coronary arteries, but a lot of other structures are often visually assessed for disease or enlargement, as quantitative assessment can be very time-consuming and not practical within the existent framework of practice. Bhaskaran and colleagues used the dataset of annotated CT images from 206 patients in order to develop a deep learning model for segmentation of structures from CT images. On the left is the overall structure of the model used, and on the right is an example of a good prediction mask, as exemplified by a die-score that is close to 1, and an example of a poor prediction with a die-score that is 0.4. Green are the ground truth labels and red are the prediction masks. On top, the ascending aorta is predicted well with excellent overlap between both masks, but on the bottom, the pulmonary artery prediction mask is missing a portion of the artery, as evident by the green area that is missing from the prediction mask. The investigators were able to achieve a die-score of 0.82 for 8 different structures. This figure shows model performance for the ascending aorta in A, descending aorta in B, superior vena cava in C, inferior vena cava in D, coronary sinus in E, pulmonary artery in F, right ventricular wall in G, and the left atrial wall in H. Moving on to myocardial perfusion imaging. Myocardial perfusion imaging is a form of stress testing which is done for the purpose of evaluating the blood flow within the coronary arteries and to evaluate changes under resting conditions and during stress. The change in coronary flow can be indicative of the presence of significant or obstructive coronary artery disease. Myocardial perfusion imaging is widely performed, and image interpretation and analysis can be time-consuming and require significant resources. This is an example of the images that are obtained during a myocardial perfusion scan. Panel A shows a single angular projection of the torso, while panel B is a single slice sinogram through the heart showing perfusion of the myocardial muscle. Panel C is a polar map with all myocardial segments represented in a single image, while panel D shows the 3 multiplanar reformatted cardiac views that are typically used to interpret these scans. These images are compared at rest and after stress, and any changes in perfusion are accordingly interpreted. In this analysis from Betancourt and colleagues from Cedars-Sinai in LA, they developed a deep learning model for the prediction of obstructive or significant coronary artery disease in more than 1,600 patients. The training dataset included patients who had both a stress test as well as an invasive coronary angiogram, which served as the ground truth for the presence of significant coronary artery disease. The investigators used 3 feature extraction units as well as 3 fully connected layers for 3 outputs, each corresponding to the probability of obstructive coronary artery disease in one of the 3 major coronary arteries, the left anterior descending artery or LAD, the left circumflex, or the right coronary artery or RCA. Finally, we will touch upon percutaneous procedures, which encompass any intervention that is done in the cardiac catheterization lab and does not involve open heart surgery. So the modality of choice in the cardiac catheterization lab is X-ray fluoroscopy. However, it doesn't provide exact imaging needed since it's 2-dimensional imaging. And secondly, the heart border is not clearly visible on fluoroscopy. These images show an example of a transeptal procedure where an operator is required to cross from the right atrium to the left atrium for a specific intervention. When that is required, the location of the septum or the border between the right and the left side is estimated based on operator experience, often a second imaging modality such as echocardiography, is also used to confirm the location. Once the septum is safely crossed, then the desired location is reached and a specific intervention is performed. Existing technology for hybrid imaging involves overlaying echocardiographic images onto fluoroscopic images in order to provide the operator with a better visualization of nearby anatomical structures and in order to maximize the chances of success while minimizing complication risk. Unfortunately, such an approach does not provide a true appreciation of the three-dimensional anatomy and relationship between structures, and in reality does not add much, especially in the eyes of an experienced operator. One of the advantages of CT imaging is that it provides three-dimensional volumetric imaging of the heart and surrounding structures, especially when contrast is used with opacification of cardiovascular structures. So deep learning has been used to co-register fluoroscopic images as well as CT scans that are typically obtained before an intervention is performed. In these cases, the spine has been used as a fiduciary marker since it's easily seen on both CT as well as fluoroscopic images. Thereafter, the model is trained to recognize specific catheters and devices used by the interventionalist, thereby creating a real-time augmented reality system to guide procedures in the catheterization lab. This way, a preoperative CT scan is obtained, three-dimensional segmentation is performed on the structures of interest, and using automated code registration of CT and X-ray images, the three-dimensional anatomy is provided to the interventionalist in real time through an augmented reality system. Such a tool has the potential of providing actual three-dimensional orientation, which not only can improve the safety of the procedure, but can also minimize time, radiation, and contrast usage. So in summary, images are a source of vital diagnostic and prognostic information. Artificial intelligence promises to improve and further optimize workflow within healthcare. In addition, the application of deep learning could help with image acquisition, analysis, and improve risk assessment. Nevertheless, the application of deep learning has its challenges, including the need to establish an accurate ground truth, which requires expertise, time, and resources. Thank you.